Okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and good evening to all participants of the 38th FARO webinar. A warm welcome to our distinguished speaker, esteemed panelists, and the dedicated organizing committee working behind the scenes. Whether you are joining us as you wrap up your day from the comfort of your home, or maybe you are still in the daylight hours in some of the region, we are grateful for your presence and hope you are in the best of health. To those celebrating, I also wish you a very blessed Eid Mubarak. All praise to Allah for granting us the opportunity to convene this for the scientific session. Today, we delve into one of the most compelling frontiers in our field, spatial fractionation radiotherapy, or SFRT. It is my distinct honor to introduce our keynote speaker, Dr. Angela
Recording in
Gizalvania.
progress.
Dr. Gizalvania currently serves as the head of the radiation oncology installation at Dr. Cipto Mangunkusumo General Hospital in Jakarta and is the president-elect of the Indonesian Radiation Oncology Society. Her expertise in this field is deeply rooted in her doctoral research, where she utilized grid devices and study about the immunology and the abscopal effect of that therapy. Today, she has been recognized as a member of the IAEA expert team in this specialized area. And joining Dr. Giselvania is a panel of experts, Professor Humaira Mahmud, Director and Chief Oncologist at Atomic Energy Cancer Hospital, Nori, Islamabad, also known as a fellow IAEA team member also in SFRT, and Dr. Mariko Kawamura, Associate Professor at Nagoya University, Japan, Mr. Wahyu Edi Wibowo, Head of Medical Physics at Dr. Cipto Mangunkusumo General Hospital, and Dr. Nicholas, a Fellow in Stereotactic Radiation Technique at Dr. Cipto Mangunkusumo General Hospital. So to begin our session efficiently, I would like to invite Dr. Gregorius Yogi, who is also here with us, President of the Indonesian Radiation Oncology Society, to deliver the opening remarks, and then will be followed by a message from Professor Yasushi Nagata, Secretary General of FARO. Dr. Ben, please, the time is yours.
Yeah, thank you very much, Dr. Rimunander. Dear colleagues, thank you so much for joining us this afternoon for the 38th FARO webinar. Before beginning, I would like to thank FARO, represented by Professor Yasushi Nagata from the Secretary General Office, and also Dr. Rimunander representing the Education and Training Committee organizing this webinar. The FARO webinars have been very useful for us. And I would say very relevant as well. The topics have been very interesting, and even though the relevance might vary across the region, but so far everything has been quite useful. So it is with great honor that we now take the helm of organizing the current webinar today. So the reason for the current topic is that because Asia is diverse, we have countries with advanced techniques, we have countries with good cancer control, but we also have areas in between where advanced techniques are available, but tumors are very large and patients suffer from local advanced cases. We are accustomed to a dogma of treating palliative cases with lower doses, simpler techniques, but the presence of temporal fractionation, which Dr. Giselvania is going to share with us this afternoon, would be a game changer, I would say. And it is so radically different from what we are used to do that it is sure to challenge you as well throughout this session. So I know you are looking forward as much to it as I do. So I'll just stop here and wish that everyone will enjoy the session. Have a blessed Holy Week for colleagues who celebrate it and long weekend for the others. Thank you very much.
Hello everyone. My name is Yasushi Nagata,
and I am Secretary General of the Federation of Organization for Radiation Oncology, FARO. I'm also a professor of emeritus of the Department of Radiation Oncology, Hiroshima University. I served as a Secretary General between 2021 and 2025. I was elected in 2025, and I am very happy to serve as a Secretary General again between 2026 and 2027. FARO was established to build strong relationships among the national radiation oncology societies across Asia, with the firm resolution to improve healthcare for patients and cooperating with member societies in research, education, and clinical practice of radiation therapy. FARO currently consists of the National Radiation Oncology organizations from 15 Asian countries and 3 corporate members. FARO is facing several problems, including how far we can include a new member of FARO, frequency of FARO meeting, financial issue, how to activate developing countries, and young radiation oncologists. I promise to do my best during this term. Thank you very much for participating in the 38th FARO webinar today. Today's topic is Beyond Uniform Dose, Rethinking Radiotherapy with Spatial Fractionation. Shrinking field technique has a long history. Field technique has been done for a long time. I remember we had a discussion that in case of hyperfractionation, which is better, small field in the morning and large field in the afternoon, or large field in the morning and small field in the afternoon. Up to now, I don't know which is better. Recently, simultaneous integrated boost SIB technique is available using IMRT technique. Today, we have 1 speaker and 4 panelists from Pakistan, Japan, and Indonesia. I hope today's webinar will help you to understand these important topics. This August 28th to 30th, FARO Estro Meeting 2026 will be held in Singapore. Please visit the FARO webinar website and register your participation. We look forward to seeing you in Singapore. In closing, I'd like to express my sincere gratitude to the speakers and panelists for today and everyone involved in organizing this webinar from Iros, Indonesia. Thank you very much for joining us today.
Thank you, Dr. Ben and Professor Nagata. And now we will go to the main event. So please, Dr. Giselvania, the time is yours, and we'll look for your presentation, please.
Thank you, Dr. Ari. It's been an honor for me to be able to present regarding this topic here. So, is my slide already visible?
Yes.
Yeah, okay, thank you. So, today I would like to talk about the beyond uniform dose rethinking radiotherapy with spatially fractionated radiation therapy. Okay. So I will briefly talk about the background, the mechanism of work, types of the SFRT, with lattice SPRT PET card, and also comparison between its SFRT techniques and conclusion. So for the background, what we usually learn is radiation kill cells as a direct cytotoxic event, and then double strand break DNA, and then the clinical outcome will happen when the cell death. But actually, radiation does more than just killing cells. So it has effect for the bystander effects, meaning that when we kill the cells, so the other cells that stands next to the cells that irradiated will also get the effects. And also there's abscopal effects, that is when the cells, tumors far from the primary tumor can also receive the effect of the radiations. And also radiation can modulate the tumor microenvironment of the tumor. So those secondary effects have distinctly different correlations, time and space with radiation than the usual direct cytotoxic effect. That's what happened during the SFRT. So usually, we know that the limitations of conventional radiotherapy treatment is unacceptable dose to the ORRs, of which we fear the damage to critical normal organs. And that is actually the first cause of the radiation therapy treatment failure, where when we do not achieve higher dose for the tumor due to we have to constrain the neighbor healthy cells. But we often meet clinical needs that unmet, like we face bulky tumors, of which too much normal tissue cannot be spared, and then also cases of radioresistant tumor, and there's also cases of relapse disease that needs re-irradiations, and then the dose tolerance has already been achieved, and we cannot go further. So that's our cases that needs problem solving. So if we think outside the box, so that's where the spatially fractionated radiation therapy comes. So instead of giving uniform dose, like the conventional radiotherapy, the spatially fractionated radiation therapy involves intentional direction of highly non-uniform radiation fluences toward the tumors. So the principle of SFRT is distinct from the standard radiation approaches, as it delivers non-uniform dose to the entire tumor, but it can effectively treating the tumor while staying within the normal tissue tolerance of the surrounding structures. So here we see that at the very left is the conventional radiotherapy. It has uniform field, but for spatially fractionated radiation therapy, we do partial irradiations. So there's the grid or the lattice, which the beam width, the width of the beams is within centimeters. And there's also mini beam. The wide beams is more than 100 micrometers, but there's also the micro beam, which is the beam width is less than 100 micrometers. Those are a kind of types of SFRT, but the clinical use is only the grid, the lattice, and those that the wide beams is within centimeters. Those in micrometers is or currently is in the preclinical trials now. So what is spatially fractionated radiation therapy? The concept of SFRT actually was proposed long time ago, over 100 years ago, in the form of grid. Grid is this spatial collimator. You can see at the right side. So that's the collimator from the brass with its hole around 1 centimeters. So that grid was discovered by Kohler in 1909 to address radiation necrosis high skin dose by reducing overall beam area during the kilovoltage and to the imaging era of radiation therapy. So in 1990s, grid therapy was used for patients with massive or recurrent tumors who had undergone previous radiations, commonly focused on palliative setting, and many reports patients with large or recurrent tumors treated with grid show good clinical response. The dose usually like 10 to 15 gray, delivered in single field with the grid block, as you can see there, with the 50 or 1 by 1 open to close areas ratio employed. As newer biological data suggested possible bystander and abscopal effect, it's the unique peak to valley dose. As you can see the diagram there, the peak and the valley dose, that makes the SFRT is unique, and it said that it is the key contributor to the such kind of effect that the SFRT give. So why do we need peak dose and why do we need the valley dose? So here we can see for tumor, if it is a big one, you can see if a big tumor usually inside is hypoxia where it is resistant to radiotherapy. You can see at the left side, it's the cold tumor where a big tumor, that kind of tumor inside hypoxia. And if we just treat the whole tumor, so we can see that these purple immune cells can also be outside the tumor, and it cannot go inside the tumor, making the inside tumor is still not penetrable by the immune system. But using that kind of spatial fractionation, we can see that at this right side, when we use like a grid, that the hole that the beam coming through, we can see that there's high dose that induce the new antigen release, and that new antigen release induce the recruitment of the T cells cytotoxic using via the uh, STING pathway response that produce interferons and chemokines. So you can see that the purple cells here, the CD8 plus T cells, lymphotoxics, and the NK cells could go inside the tumor and make the response is more massive rather than the cold tumor where the immune system cannot go inside the tumor. Yeah, so SFRT has been used since the era of orthovoltage, but at that time, during the advancement of the mega voltage machine, so during the inventions of the IMRT, SBRT, so grid was left behind. But currently, people start to think again about this SFRT, and so there currently the reintroduction of SFRT. But currently, SFRT is still not commonly used because some concerns about the underdose area for the tumor. But actually, we really don't need to cover all if we have a good mechanism of the SFRT. However, the SFRT working mechanisms remains poorly understood until today. And then this is another type of the SFRT is the lattice radiotherapy. So if we says about grid, it's usually using that collimator. It's a 2D grid radiation field, but lattice is the 3D form of the grid. It was developed by Wu et al. In around 2010. Lattice is the 3D technical extension of the 2D grid technique. So when we do lattice, so we usually do delineate the GTV and then put around 1 centimeters inward margin and then start put vertices there. So the vertices there is the one that will have the high dose. The high dose for the vertices can be like 10 to 25 gray perfections. And this vertex diameter usually around 0.5 centimeters to 1.5 centimeters, depending on the size of the tumor. And between vertices, it usually separated between 2 to 5 centimeters. And we keep the vertices volume to the the whole GTV volume, the ratio is between 1 to 10%. And then for the valley, meaning that the area that is not radiated, we keep the dose for the valley under 5 gray fractions. And dose to the GTV margins at the edge of the tumor is around 2 to 5 gray. Yes. So how do we put the vertices? We can put it manually, just like in my institution, we put it manually. We usually use help contour. This is the yellow one is the help contour to make it easier for our physicists to plan to achieve the constraint that we saw before. So it usually like horizontally like 1.5 centimeters and around 0.8 vertically. But actually there's a script. So there's script for automatic grid placement for lattice SBRT. This is from James. It's from Mayo Clinics. So they usually can place the vertices automatically, and the trials shows that the script do better than when it is done manually. So this another how they put the vertices, so can put the PTV and the PTV avoid. It is also another way to put vertices. And when we treat patients with lattice, so actually because we use high dose and we usually use lattice for a deep-seated tumor, so the technical requirements for LRT can be best equated to that of SRS or SBRT. So we use stereotactic setup, and then that includes the precise image guidance and respiratory motion management also if indicated in the moving organ. And the robustness of in the patient setup and immobilization is essential, not so much because of the concern of normal tissue toxicity outside the tumor, but the potential blurring effect of the vertices dose and the possible presence of critical structures when the organ moving. Okay. And for the QA, the same patient-specific QA standard like IMRTV MET based SRS SPRT QA protocols or procedures is used for this lattice RT. And if we see the publications from Nina Mayer, so how people do SFRT, so they have a survey here, a total 73 responses from 51 radiation oncologists and 17 physicists and 5 radiobiologists who is member of Great Lattice microbeam working group members and FLASH working group members and the RSS membership. So they usually treat the primary tumor with SFRT, and usually the bulky one, 100% they treat the bulky one. And we also consider that use of grid is 53%, use of lattice among the members, 53%. And how do they prescribe? Mostly prescribed like 15 gray in 1 fractions, some also 18 gray, and some also 20 gray in 1 fraction. And then you can also see there that they do they can do the combination with systemic therapies along with the chemotherapy, but that's only like 20% because some saying that we would like to induce the immune cells, but with chemotherapy, some of our immune cells will die. So that's why it's not so popular to to combine with the chemotherapy, but it is said that usually SFRT with the immunotherapy can be more synergistic. But there's not so many trials that has already result with the combinations of the SFRT and the immunotherapy. And these are some of the practice patterns of the SFRT in sarcoma, in lung cancer, in the first one that's in head and neck. So distribution of disease sites, you can see that some treated metastasis to lymph nodes, to primary head and neck cancer, to intra-abdominal structures, metastatic to lungs, lung cancer primary sarcoma, bones, cervical cancer, breast, malignant melanoma, prostate, metastatic to brain, a very small percentage, but and malignant brain tumor. And here's also some use that for the palliative and some use that for the curative intents, and those are the dose. So usually the most common dose is single fractions of 15 gray. And there's another, aside from grid and lattice, there's also another forms of the SFRT, it's the SBRT-PETI. SBRT-PETI means the partial tumor irradiation targeting hypoxic segment of bulky tumors. So this SBRT-PETI was developed by Dr. Slavisa Tubin from Austria. So his hypothesis is the hypoxic tumor cells is more radioresistant compared to the normoxic tumor, which is radiosensitive. So hypoxic tumor will need more high dose, but it should be targeted to the hypoxic area, of which the hypoxic area cells, the resistant hypoxic cells will survive inductive radiation better than normoxic cells, leading to higher radiations, hypoxic induced bystander effect, or abscopal effect potential. So by giving that higher dose radiations, they will release the pro-angiogenic and anti-angiogenic cytokines that will induce the tumor abscopal signals. So this is the idea is to treat the hypoxic tumor at least with 10 gray, and then it will give anti-tumor abscopal signals, and it will chase the tumor. So Dr. Slavisa Tubin usually treat like this. So this is the area hypoxic. He called it the BTV, bystander tumor volume hypoxic segment. So this is the only treated part for the SBRT-PATI. So it's just like maybe around 70% of the whole tumor, but the result is sometimes can be achieved until complete response for the whole tumor just by irradiate the partial tumor only like 70% of the total mass. So this is the result of his SBRT-PATI, and he says that abscopal effects is often happen with this kind of technique. So here is the area that is not treated with radiations, but it also shrinks during the evaluations post radiation. So you can see there that only treating part of the tumor can induce the whole tumor shrinkage. This is another types of the SFRT, the SCART. It's the stereotactic central for ablative radiation therapy. So SCART concept was invented by Dr. Wei Xian and Jun Yang. Prof. Jun Yang is a medical physicist. So while the SBRT-PETI approach is more biological to the hypoxic segment, this SCART approach is more from the physicist aspect. So when Dr. Jun Yang, the medical physicist, create this SCART concept, the idea is to make it a bigger area that could receive high dose, while keeping the edge area, the normal tissue, is safe. And also this kind of SCART concept is easy to plan compared to the other like lattice or SBRT patty. This is the SCART planning is very fast and very easy. It's around like he did that in 3 minutes, but I think here perhaps like for 5 to 10 minutes. Yeah, but it's very fast because the concept is to create a tube inside the tumor. This tube called the STV, it will receive the ablative dose. The dose is around like 15 to 24 gray. And keeping the area of the edge of the tumor is 5 gray. So the rationale is the tumor core is hypoxic, and the peripheral is normostic. And by giving ablative dose in the center, low dose in the tumor periphery, it will activate the bystander and abscopal effect, mitigating the immunosuppressive effect. So these are the prescription dose for this card, and this is the tissue dose constraint, meaning the tumor edge that in that near the normal tissue. So you can see that if grid and if lattice, the percentage of the GTV, the percentage of the vertices that is given high dose compared to the volume of the whole GTV is usually like only 1 to 2% that we can achieve with this kind of approach, the STV. The volume is like a 3% to 10%, much higher, because how do we uh, do the STV? So the STV dimension is the GTV dimensions times the tissue dose constraints per prescription dose. So if we have a tumor like 9 centimeters, and we would like to give the prescription dose like 15 gray, while keeping the tumor edge is like 5 gray. So 5 gray to 15 gray is 1/3. So the STV dimension should be 1/3 of the whole GTV dimension. So if the GTV is 9 centimeters, so the STV can be just like 3 centimeters. For the other example, if we want to give like 20 gray while keeping the normal tissue is 5 gray, so it's 1/4, 5 per 20. So if we have a GTV dimension of 10 centimeters, so the STV should be like 2.5 centimeters. So it's doing that, so we will have this kind of tube. So Dr. Junyang taught us that. We were lucky that Professor Junyang came to our hospital last month and taught himself about how to do this card. So the usual dose, he gave like 3 fractions times 15 to 24 gray. And the surrounding tissue conference is 3 to 5 gray. And the result is, it's a good result actually, and easy to use, to plan. compared to the other technique, with also no significant toxicities, as you can see there. And these are some clinical cases in our department. So the first one, this is a great case. So this is a female, 18 years old with breast cancer. The mass is so bulky, it's 25 centimeters. We give like single grid dose of 15 gray, followed by IMRT 43 gray in 16 fractions and another booster. So this is the grid. You can see that can see the field. And here are the first few fractions. So it responds so good. And after 2 weeks, we can already see this kind of conditions of the breast. And this is after 1 month and 2 months and 3 months after. So it's a very good results that we have from the grid therapy. And this is another case with huge HCC, hepatocellular carcinoma. This patient was first consulted for surgery, but the surgery was canceled only a few days before the D-days. The surgeons would not do the surgery, and this is also too big for days, and the patients also could not afford the systemic therapy. So we do the SFRT here, because if we do the usual SBRT technique, the normal liver tissue is less than 700 cc. We cannot do optimal. So we just do SFRT single dose 15 gray, followed by a very low dose of 15 gray in 5 fractions. And then in almost 2 months, the mass shrinked significantly, because the dose the first time we give is quite small. So we added SBRT 24 gray in 3 fractions. And this results very good. But this is when we still use the grid, we can see that grid mark on the patient's skin, which is very unique. It's not very common actually. So this is one patient that I found that has a very significant grid mark on his skin. But the result is very good. We can see this is the pre-SFRT. The tumor is very big, like 12 centimeters with AFP, 164. And then 5 months after is 6 centimeters times 4.5. 8 months after is 1.65 for the AFP. It's already normal. Residual mass is 5 centimeters, but it's already non-viable. So it's a complete response. Sorry. So it's a complete response for this patient. And the patient is still alive and well and complete response for today. It's already like 2 years now. And this is another case. This is lattice. So for the cervical cancer, we use lattice because we would like to avoid the rectum and the bladder. We could not do that using the grid because it's a 2D. So this this lattice works quite fast. It's 14 fractions, and the shrinkage is already remarkable. And during brachytherapy, it's almost the mass is very small already. And this is also another case of HCC with lattice, very painful in elderly, 76 years old. So you can the pulse is 8 to 9, and we give a single dose of lattice 15 gray, followed by SPRT 5 times 8 gray twice a week, and this is the result. So it's a good result, and on top of that, the patients also have a good quality of life, because usually the patient have a very painful pain. Now pain-free. And this is one of the case that we do SBRT PET, but in our experience, SBRT PET is difficult for us because we don't have a PET CT always available for every cases, of which the PET CT is one of the requirement to do the SBRT PET to recognize the hypoxic area. That the Dr. Slavisa Tubin actually says that so there's no PET CT scan, we can just do the bystander target volume with the necrotic area plus 5 millimeters, and then this is the PIM is the immune, so it's GTV plus 1 centimeter outside the GTV. It's where the immune system have to be kept safe. So the other problem for the SBRT PET is also sometimes the necrotic area is so big that it will not give the ideal scenario, because the ideal scenario, the hypoxic area, the BTV takes around only 1/3 of the GTV, so that the planning will be good. But in this case, when the necrotic area is already around like 50%, the immune, the PIM, peripheral immune margin will not be able to be spared optimally because of the unfavorable relationship between the BTV here and the GTV, because the necrotic part is large and we will not achieve very low dose to keep the PIM safe outside the GTV. And this is another case that we do with SCART. So this is the summations of the treatment. The inside is the SCART. This is a pancreatic tumor. Outside is the IMRT. The SCART is fast, and the result is so good. So if I would like to compare between all of those SFRT techniques, so when we would like to choose a technique, so it will be, we have to take a look at the tumor locations. When for grade 2D, it's only good for the superficial tumor. But for the deep-seated tumor, it's not advisable to do the grade 2D. Lattice and SBRT PET and SCART, it's all good for the deep-seated tumor that is surrounded by OARs. But for the SBRT PET, because you need to recognize the hypoxic area, so you need to have the FDG PET or the PET CT for hypoxic area, such as the ATSM-Q64 available, in order to better targeting the necessary BTV. And for the size of the tumor, the collimator grid is also like a fixed collimator with its hole is 1 centimeter. That's why you need to have a bulky tumor, a real bulky tumor, to be able to fit with the grid. The other, since it's we could delineate it freely, so it's not really depend on the size of the tumor. Even for lattice, when we have a small tumor, we can have vertices as small as like 0.5 centimeters. And if we have a bulky tumor, we could have vertex like 1.5 centimeters. So it can be adjust based on the size of the tumor. That's also for the SBRT PET and the SCART. And for the time needed for planning, so for the grid 2D is very fast, because it's really just need to do like a single beam or opposing, but close or the OAR with the MLC. Lattice, I guess this is the longest times needed to plan, because you have a lot of vertices, while you need to keep the value dose to 5 gray, as low as that, to be able to induce the site effectively. while the SBRT is like SBRT, like planning SBRT, but if the necrotic part, the hypoxic part is big, while the GTV compared to the GTV as my case before, it will be difficult to achieve. As for SCART, this is very easy and fast because instead of you make a lot of prostheses, you just need one tube. That's the STV, and yeah, the STV usually 1/3 of the GTV, so it's like 30% or less. And for the verifications, for grid, since it is outside, so as long as it is outside and you can keep it safe. So aside from cone beam, EPIC can be used. So like in our place, we do not have the cone beam for the machines that compatible to our grid, so we use the EPIC. But it's a tumor outside and everything just tumor. We will close. We will not put anything OARs as the target. And for lattice, SBRT, PET, and SCART, so it's all equal to how we do SBRT. So for just like my slides before, so from the immobilizations, motion management, and also the QA of like the SBRT. So we talk about the future direction. So in the past, SFRT has been used for the orthovoltage therapy using the grids from the 90s, 19s. And now we use it as grid lattice. We could use that with TOMO. We can also use the SFRT with proton. And there's also SBRT PETI. And in the future, perhaps we use also the mini beam and the flash. And this is also the kind of idea that I think, and also I also have ever seen this also from Prof. Junya. So I think I agree with him. So perhaps for small tumor, we can do the SRS, SRT, and SBRT medium tumor with conventional fractionations, and bulky tumor, since we cannot fit everything, so we just do the SFRT. So that's, I think, the end of my presentation. So SFRT shows promising results. And in some cases, it even enables the palliative cases toward curative intent. And it has satisfactory treatment results with better quality of eyes with no significant toxicity. Thank you so much. Here's the pictures of our SFRT group in IAEA and Prof. Humera Mahmud. Thank you. That's all from me.
Thank you. Thank you, Dr. Giselle, for the comprehensive presentations. We learned a lot from your presentation. Thank you very much once again. And so we would like to continue to our panelists. We have here first Professor Humera Mahmud from Nori. Please, Professor Humera, you can start your discussion. Thank you.
Okay, good morning, good evening, and good afternoon. I would like to thank Dr. Ari and his team for organizing this event and inviting me as panelist. And I would also like to congratulate Giselle for giving us a highly, highly informative and excellent presentation. So this topic of SFRT is really very close to my heart, as it is something with the help of which we are now able to give some relief to patients with tumors that were otherwise not amenable to any treatment, no matter it was systemic treatment or conventional radiation. And with the help of SFRT, we can now target very huge recurrent tumors present anywhere in the body, either in brain, head and neck, chest, abdomen, or pelvis. And as far as my experience is concerned, in fact, we started specially fractionated radiotherapy in 2023 after training of one of our medical physicists in a workshop organized by International Atomic Energy Agency in Vienna in 2023. And till today, we have now been able to treat almost 30 patients with a variety of sites, sizes, and histopathologies. And also, we have been using a variety of dosage schedules according to these three criteria. And when we started, we were quite apprehensive, so we used to do fractionated schedule, usually using 24 grain 3 fractions. But as we got experienced and we became more confident, then we started using mostly single fraction in the dose of 10 to 15 gray, followed by conventional fractionation, either hypofractionated or conventional fractionation, depending upon the site and size of the tumor. So till now, we have mostly used this technique in sarcomas, but also we have found it to be very, very useful in disease present anywhere in head and neck, also breast, chest, abdomen, and pelvis for huge primary as well as metastatic lesions. And we have found the very, I must say, encouraging responses with the almost negligible or no toxicity in majority of our patients. The technique that we are using since the start of SFRT in my hospital is lattice radiotherapy, and we deliver it using VMAT technique and with the help of cone beam CT. When we were encouraged with the results of the patients that we treated at Noori, so we shared our experience through a number of presentations in a number of events, including we did an educational session on SFRT for Espronet, which is Asia Pacific Radiation Oncology Network, and Giselle is always there. And me and Giselle, as she has already shown, we have been part of a consultative meeting of International Atomic Energy Agency for formulating a research protocol with the title of Spartan that is going to be started very soon. And last but not the least, I would here like to appreciate my team of medical physicists, as they have been able to make their own grid indigenously, so that now we can use it in our patients where we don't have time for planning with lattice technique. And we will be able to get, I think, the same good results as we are already having with lattice technique. So this was from my side. And again, I would like to thank you for giving me this opportunity to speak about experience of SFRT in my hospital. And taking the opportunity of this session, I would like to invite you all to my country. Ari and Wahyu have already visited us, and I invite Angela, Giselle, as well as others to visit my homeland. Thank you. Thank you so much.
Thank you, Professor Humera. Dr. Giselle, is there something you would like to comment or no?
And no, not really. I think Prof. Humera and I have been doing the SFRT and enjoy the results from the SFRT because, for cases that too big or too resistant, that it can respond well, right?
Yes. Yeah, we were looking forward for the Sparta. Okay. So the next panelist will be Dr. Mariko. Please, Dr. Mariko, the time is yours.
Hello, Giselle. Thank you for a great talk. And first, don't we have to go through those Q&A? There are plenty of questions from the audience. Is that okay? We just go through with the panelists.
I think we do the panelists first and then after that.
Okay. In that case, okay. So I'm not doing FSRT. So I've heard of this from you like 1 year ago. But since I don't have the experience, I'm not quite sure to who I should apply this treatment to, because you've shown breast cancer and HCC, which are somewhat sensitive to radiotherapy itself. So even huge tumor, we can somewhat control with the high dose conventional, or like maybe 3-4 gray per fraction till up to like 13 or 15 or 18 fraction. Then breast cancer, we can somewhat control them locally. So I don't know if you want into which candidate do you want to use these FSRT. And another thing is that how do you add those FSRT dose to the later conventional dose? I mean, the fractional dose is different. How do you add those two different dose in like to evaluate the organ at risk doses? Do you get what I mean?
Yeah, I know. So, should I just answer now?
Yes, please.
Yes,
Yeah. So, just the calculation. So, like, grid 1 times 15 gray, it equals like 3.8 gray, and then 5 gray for dose prescription of 20 gray for grid, it's equal like 5 gray. So there's the calculation, special calculation. Yeah, so that's that. But like for lattice, so basically we treat like the hole is like uh, the dose is like 2 to 5 gray, right? In the edge, so we can consider like it's like they will have like 5 gray. And also SCART is the dose at the edge of the tumor homogeneously is 5 gray. So we can assume that it's 5 gray. So when we do the conventional or another techniques that follow the SFRT, we just reduce the dose by the 5 gray, for example.
You never put the hot dolls right next to the organ at risk. You just put them right in the middle of the tumor, you mean? I might not understand. Maybe.
the hotspots.
Should I add?
This is the first. Yes, Professor Humera, maybe you want to
Yes.
add.
Okay, particularly with regard to sparing of organs at risk, as far as because we are mainly doing lattice radiation. With lattice, we can easily spare peripheral organs as well as if there is any, OAR within the tumor, even that can be spared. For peripheral OARs, we are all our vertice volume that we call where we are prescribing our high dose. It's already 1 centimeter inside actual GTV. So this is how we can easily spare peripheral organs at risk. And as far as those which are within the tumor, what we do is that we plan to place our vertices in areas that are away from those organs, and so as to keep the dose to the normal organs or the valleys that are present in between those vertices less than 5 gray. So here we can spare OARs even better than SBRT. This is what I have found.
But in that case, do we have the marginal recurrence?
No, usually not, because after all, this is palliation, and the periphery also receives sufficient dose. But we do take care of skin if a tumor is close to the skin, but skin is not involved. So we always take skin also as an OAR. We try to keep the dose to skin as low as possible, as well as the bones.
So it's more like quad chop kind of treatment. No, maybe good for like 1 year, but if they live longer, then we have to be careful about the margin.
Yes, sure.
Okay, and one more question. Sorry, about the immunotherapy. You said you've shown that paper that immunotherapy is done only in like 33% concurrently.
Oh yeah.
Theoretically, I thought it was very good they combined. So do you have any
Right.
experience of combining, and did you find any good results?
Combining, yes, at the HCC, a good result, yes, but we do not have like the use an arm with and without. So yeah, that's why. And that's also your first questions about you usually treat the big tumor, but with conventional, and that's also okay. So yeah, that's why uh, the IAA would like to start the Spartan when we can use two arms with the conventional versus the SFRT. So we really know the difference. But I have an experience when one of our colleagues sent me a case of cervical cancers post EBRT 50 gray. What when the patients came, the tumor is still so big that even you put needles there, it's still just so big. It's like the patients haven't been irradiated at all. So yeah, I do just single lattice and wait like a week or two, and then it shrinks so I can do the brachy. Yeah, so I think it makes difference between just conventional and you put SFRT and then the tumor response and you can do the brachy.
Okay, thank you. There's so many questions coming in, so I'll stop mine.
Thank you, Dr. Mariko. So yeah, we actually already 1 hour, but we can expand it at like another half an hour, I think. So the next is Mr. Wahyu Ediwibowo as the medical physicist from Indonesia. Please, I give you the time.
Hello everyone. Thank you for Dr. Ari, Dr. Giselle, and others panelists. I would like to thanks FARO to invite me as a panelist. I think good presentation and good discussion between Dr. Giselle and panelists about the clinical impact for the SFRT. But we should remember about the dose delivery. I'm talking as a medical physicist because we should ensure about the dose delivery and accuracy for the patient equal to prescription, the TPS, and the paper and the delivery. The important thing for the all of the clinical implementation is the commissioning. Dr. Giselle already mentioned about the quality assurance. I think for the like the MRT, VMAT, SBRT, or SRS or other technique, we should do quality assurance. But the very crucial and critical for the clinical implementation is commissioning. Even we use the grid therapy, lattice, or the SBRT PETI or SCART, we should done about the commissioning. Like the grid therapy, as my experience, we have done about the grid transmission factor, peak to value dose profile, output factor, and more different between the grid and the lattice because lattice we use the TPS fully and we use the MLC. They more complex about the distribution between the peak and valley and high dose very short. So I think commissioning is very important before we do the SFRT. I think enough and we can discuss about the commissioning or others. Thank you, Dr. Ari.
Okay, thank you, Dr. Wahyu. Please, Dr. Giselle, do you want to?
I have no additional
Okay.
comment.
Okay, so thank you, Mr. Wahyu, for your insights. It's very valuable from the medical physics point of view, and we should really consider about that. So the last panelist is Dr. Nicholas. Please, the time is yours.
Yes. Thank you very much, Dr. Ari, and thank you very much for inviting me in these amazing sessions. And it was such an honor for me Maybe I would like to speak a little bit about this technique SFRT, which is very interesting and piqued my interest ever since I was in residency program, because SFRT bring a very new concept, because for a very long time we know uh, the cold spot is a very is not something that we would like to have in a radiation therapy. But in this technique SFRT, we are deliberately trying to put a very a large sum of cold spot in our treatment. So for if we can see, SFRT is a very new concept, and clinically it has been giving great results from Dr. Gisel's presentation. A lot of patients have a great reduction in terms of tumor size, that it showed a very good results. And maybe for a few things that I want to add is, currently there's a couple of phase 3 trials which has been picking a lot of interest also, that is comparing lattice and conventionals. And also there is phase 2 trials which is trying to see the results of SFRT in terms of lattice that is combining with immunotherapy. Maybe after this trial is coming out, we can have a better showing about what really this lattice therapy really give best in what kind of patients. And also, I would like to give one question to Dr. Giselle, maybe in the perspective of those centers who hasn't tried any lattice radiotherapy, and we know that it was quite hard to achieve a good planning. Can it be done maybe to build confidence first for those patients who has to go under a palliative schema? Can they try to put a little bit of vertex first before they can become more confident in doing a better planning? Maybe like for the first patient, they can do only 3 vertex, and then the medical physicist can try to build the confidence of after a few vertex, the planning is achievable. They can start to build up the confidence to achieve more robust planning. Maybe that's from me. Thank you very much.
Thank you, Dr.
Yeah.
Please.
Okay. So there's the requirement like you need to achieve at least 1% volume of vertices compared to the whole GTV to be able to induce such kind of response. Yeah. So yeah, if it is too small, I mean like the mass is so big, but you put only like 3 vertices, probably it won't work.
Yes.
Yeah.
Okay, thank you very
I
much,
think
Dr.
that's
Giselle.
from my side, and also that I would like to inform that this SFRT is it's another kind of system compared to the conventional fractionation. So it's not the same. So it doesn't work the same. So yeah, I mean like SBRT PETI, it never irradiate the whole tumor, but it can achieve complete response. So I see questions here like since SFRT usually followed by conventional EBRT, how do we account that the effect is from SFRT technique and not from the conventional? So yeah, the SFRT is like to induce, but if it is just done one time, it usually not last longer. So we still need the conventional radiotherapy. But if we just do the conventional radiotherapy, usually we do not see a dramatic response of the shrinkage of the tumor, or the when the pain is gone is very dramatic. If we use the SFRT, it's what I see. Yeah, but another proof is that from the SBRT that never cover the whole tumor but still get the response. Thank you.
Thank you, Dr. Giselle. Yes, I see also many of the questions is regarding the peripheral dose. Many are worried about because the peripheral dose is only 5 grays, and we don't know how to match with the conventional dose afterwards. Sometimes we don't know about the like Dr. Mariko said about the marginal recurrence. So yeah, I think that's one also factor that we need to consider. But I think yes, as you said that this is a very different system. So it is a very different mechanism to achieve the response from the tumor. So I think probably 5 grays in the perimeter is actually it is the dose needed to the peripheral, and we don't need to worry about the recurrence of the marginal recurrence. What do you think?
Sorry, say that again.
Yeah, many are asking about the peripheral dose, which is only 5 grays, and then many are asking about the calculations to combine it with the conventional, because we don't know whether the peripheral dose will be enough to achieve
All right.
the the response without any marginal recurrence.
Yeah, yeah. So I think that was that I was answered previously. So it's a different kind of mechanism. Uh, you don't need to cover all the dose homogeneously to give that site of effect, because by conventional radiation therapy you only depend on the cytotoxic effect. So if you not cover, then the tumor won't die because you do not cover it, because you depend on the cytotoxic effect only. But from this SFRT, it also has the vascular mechanism, and then also the immune induced mechanism, which is doesn't really works with margin. Yeah, that the SBRT patty is the proof that even you never cover the edge of the tumor, it still can cover, give a complete response.
Okay, thank you. So we will like to continue to the Q&A. It is already a lot, but I think many are questioning the same question. So I will choose. There is one question actually from Professor Hong Kyun Woo. Professor Wu asked, does FSRT use only one port? So FSRT is usually followed by IMRT, and it looks like the estimation of those distribution is not easy with FSRT. What do you think, Dr. Gisa?
There's only one port, perhaps like one time, one
Yeah.
fraction.
Hmm.
Yeah. So the one who use grid and lattice usually do a single dose at the front, but like SCART, they use 3 times because I said like one time is not enough. And the estimation of the dose distribution, yeah, that's true that it's not easy, but anyway, just like calculate it as like 5 gray, because usually we keep the edge of the tumor is less than 5 gray at least. So anything inside the tumor is considered like the hot at the like SID, like it's the hot part. But since we keep the edge of the tumor is less than 5 gray, so that's how we calculate the dose is like 5 gray.
Okay. So does SFRT usually followed by MRT, or when would you choose that? Okay, this patient I will use only scar or only lattice without followed by MRT, or every patient should followed by MRT afterwards?
Well, though some people use only like grid or lattice single dose, usually for palliative cases or to relieve painful pain, cancer pain. But usually I use the followed by IMRT or SPRT. Why? Because I've tried using only SFRT. Uh, it it give a good shrinkage, fast, and relief from the pain. But in a few days or weeks, it gets bigger. It gets big again. So it's like that. It cannot maintain. So it gives a good induction to shrink, but it cannot maintain. That's why we follow by the IMRT or the SPRT.
So I think one of the key points here is the shrinkage of the tumor. So you use SFRT mainly to reduce the burden of the
Yeah,
tumors. Okay.
yeah, that's right.
Okay, so would you like to choose a question from Q&A, or should I choose it because there's so many questions?
Just choose it.
Okay, I think a lot of questions asking about the constraint, but I think you have mentioned that the point is because the marginal dose is 5 gray, so actually we don't have specific OAR constraint or protocol, right? Yeah, okay. And also question about SFRT. Could SFRT replace conventional fractionation? I think the data is not really that sufficient right now. So, and then, okay, for the lattice, if we plan with female technique, what is the dose for space? How much minimum lower dose of prescription should be?
Sorry.
The minimum lower dose of prescription. Do
Uh,
you go only 5 or maybe lower than 5 is
it is
what?
set like 10 to 25, but most people said um, 15 is the yeah, okay, 15. 15
15 in
is
the
the
max.
most. Is no you can use like 20,
Yeah.
24, 25,
And
but
about
15 is the
the
most common dose used.
okay. And for the margin, is it always 5 or you can go under from
So
5?
like SBRT patty, it Dr. Tubin always push the pin to the lowest dose. So even if it is 1 gray, it will be 1 gray from 19 gray to 1 gray. Yeah. So he counts on the abscopal effect induced the bystander effect.
Okay, and then okay, I think this is interesting. What is the main factors to consider when selecting patient to SFRT? What is the primary exclusion criteria in the treatment of bulky tumor? And also, what are the expected side effects associated with SFRT? Is from
So
Dr. Uran Cimek segment.
yeah, so the the one.
The main factors to consider when selecting patients for
Okay,
SFRT.
yeah. So it needs to be a solid tumor, I think, solid, and then we need to put the vertices or vertex inside the tumor, and we give margin inside 1 centimeter first, and then draw the vertices inside that 1 border centimeters area inside there. So it will be give like margin to the surrounding normal tissue, so it will be safe. So the vertex 15 gray not expected to you miss it to the normal organ outside. And also if there's you don't put vertex in the normal organ, if it is inside even if it is inside your treatment, like the bone or the vascular, you should avoid that. So only tumor you can treat with the high dose. So I think that's if you can do that, then it's a good selections of the patient. So patients that usually have a big tumor that you feel that this cannot respond with conventional because it's just too big. So we do that SFRT. So like for cervical cancers, if it is too big and we were afraid that it will not get shrink during brachytherapy as expected. So yeah, we just give lattice at first and then the conventional fractionation. And yeah, usually it works and the brachy will always be able to be done.
Okay. Nico, you want to add something?
Yes, thank you very much, Dr. Ari. So maybe I would like to add, maybe right now we can see that the most mature data is only from 2D grid therapy because like 2D grid therapy has been there for a long time. Maybe one of the most recent trial which is still recruiting is palliative PAL, a lattice PAL trial, which is starting at 2025, which is the newest trial comparing lattice therapy and conventional. Maybe with the trial result, it will really answers a lot of questions that whether this lattice therapy really, this SFRT really give a big impact. But currently, I think Dr. Giselle will agree that in the clinical practice, lattice has been a very uh, giving a very good result to our patient, especially in bulky tumor. So maybe it is a very good treatment of choice that we can give right now for while waiting for the newest data from those trials. Thank you very much.
Okay. Okay, so I think because of the time, maybe some questions are not answered, but I think in any other opportunity we can. I hope that we can meet each other again, and maybe we can have some more fruitful discussion. So, Giselle, maybe you have a closing statement before the closing of the webinar.
Oh, yeah. Thank you, everyone. Thank you for listening today. Thank you, Dr. Mariko, Prof. Humera, Dr. Mr. Wahyu, Dr.
Yes.
Nico, and Dr. Ari, and everyone. Thank you so much, and the FARO officers.
Yes,
And
thank you.
thank you,
Yes,
everyone.
thank you once
And
again,
also,
Dr. Giselle, and also
Thank you
thank you
very
for
much.
the panelists and officers. So, with this, we conclude the webinar. Thank you once again, and see you next time in another FARO webinar. Thank you.
Thank you.